Here's the follow-up video of the dislocated three-piece IOL that was referred to me. Here I'm bringing up the optic above the iris in a bimanual fashion in preparation for iris suture fixation. And here I'm using a tenofovir on a CIF4 needle and in a bimanual fashion, again, holding the needle driver here and with my left hand. I'm using a Sinskey hook with my right hand, and this is actually under the optic. I'm tenting up the optic. This will tent up the haptic and allows me to see the haptic a bit easier because remember the haptic is under the iris. And so here the needle captures the haptic and then comes out through the cornea on the opposite side. And now we're going to do the same thing for the other haptic. Again, this other haptic is under the iris, so I'm going to use a Sinskey hook to push up on the optic while simultaneously with my other hand capture the haptic here. And so again, this is in a bimanual fashion. Once the needle captures the haptic, it will come out through the cornea on this side, and then basically kind of similar to the pupilloplasty, we're going to cut the two needles off because we won't need them afterwards. So I've cut the needle off, and then what I do then is you have to externalize the two suture ends. So again, in this case, here's the haptic, and then there was a suture coming out from this side, went under the haptic and has come out to the other side. So I've externalized both suture ends. You're going to do it for both sides. So I'm going to just focus on this side here. And then basically, you're going to tie it 3-1-1. Now, I'm using the Mckenna suture technique. There are, again, many variations. And so the knot will actually slide into the anterior chamber. And so here's the second throw. And then the third throw here. And then as the knot goes into the AC, again, this will be repeated on this side as well. You will need to enter the AC and then trim the suture ends. I use horizontal scissors from Microsurgical Technology to do this. And here's the final product. So here again is the optic. I've pushed it behind the iris, and these are the two suture knots that have been trimmed. Now, there is no superior technique. There are many ways of suturing an IOL, and till now, there is not a superior technique. There are certainly more popular options, and I use all different types of techniques. But I feel that there are certainly benefits that should be highlighted in regards to iris suture fixation. So first of all, it's somewhat less invasive because you're only using often just 4 paracentesis incisions. You don't need a main incision if you already have a dislocated IOL. Also, you're not using scleral incisions. So with the Yamane technique or with scleral fixated IOLs with Gore-Tex, you're going to have to penetrate at least 2 sclerotomies or 4 sclerotomies if you're going to do something like an Acryos fixated IOL. Number 2, it's relatively quick to do, and the quicker the procedure, the faster the recovery. These eyes have already had another surgery before, so if you can get through the second surgery a bit quicker, it'll be less invasive on the eye. Often with the Yamane technique or with Acryos fixated IOLs, you need infusion. A lot of anterior segment surgeons will use an AC maintainer. And again, that'll certainly reduce the endothelial cell count. You can, of course, do posterior infusion, but with iris sutured IOLs, you often don't even need infusion for these cases. Another thing I want to highlight is that because you're fixating the IOL to a planar structure, because the iris is planar, you often won't get as much problem with tilt as you would with the Yamane technique. So in terms of tilt, if you're fixating on a planar surface, you're less likely to run into that issue. Another key point is that the knots that are here, highlighted here, they're actually inside the eye. So you never have to get concerned about the knots eroding with time. So with Gore-Tex suture, when you fixate them to the sclera, there is a risk down the road. It can be a year, 2 years, 5 years, 10 years, where it will erode through the conjunctiva, and that can be problematic. It will certainly require more work, and of course, there's a risk of endophthalmitis. The same thing with the Yamane technique. When you create the flange, It's not common, but certainly it can erode through the conjunctiva, especially if you create a large terminal end. And there certainly are cases of the flange extruding a year or a few years later. Again, with these knots, you never have to worry about them extruding. I always think that with these sutured cases, you don't want to just think about the short-term benefit, but you also want to think about the long-term benefit. Now, of course, with iris suture fixation, if not done properly, you can get ovalization, and it's almost like a cat's eye appearance because the suture creates tension. But what you can do, as in someone in this case, is once you're done, you can actually pull up on the iris on the opposite side of the knot, and that will reduce the tension, and you'll be able to get a more circular pupil. Now, in terms of UGG syndrome, till now, all sutured IOLs, whether it's iris fixated, scleral fixated, Yamane technique, they all have an increased risk of UGG syndrome. There is not one specific technique that produces UGG syndrome more than one other technique. I really believe that UGG syndrome can be reduced with proper technique as well as proper post-operative management in terms of prevention. So the dosing of steroids afterwards is paramount. So in summary, there is no superior technique to sutured IOLs. I use all techniques, and in this particular video, I wanted to highlight some of the unique benefits for iris sutured IOLs. I hope you found this video to be useful.